Good morning. All right. Oh, you can sit right here, Brett. Thank you. I feel like I'm a teacher or something. This is fantastic. Well, thanks everybody for getting up early this morning for the keynote panel. Well, actually, you guys were up here earlier, but this particular panel is very close to home for me, and so I think before we jump in and have everybody take a nice intro, what I wanted to talk about is, so my background, it's kind of interesting that I'm up here because I think some people might know this story, but I'm probably new to most of you. So the reality is when I was young, I was, and maybe some people have a similar background, but I grew up, I was on Medicaid. I had housing assistance, I had a variety of government services. So when I say it's close to home, I mean it. And actually, I was writing a book that actually will come out. I'm part of a guide to analytics for government. So I encourage you to look for it. It comes out in June. And as I was writing the book, I actually was thinking about this very subject and thinking, geez, when I look back on my time, certainly the Medicaid system, the government services system did a tremendous amount of help for me, of course, because I wouldn't be up here speaking to you if I wasn't healthy and things didn't work out well. But I'll be honest with you, and if you read the book, you'll see as well as, I suffer from a variety of chronic conditions, unfortunately. One of them being GERD, another one being peptic ulcers. And as I was thinking about this and I was drawing back on this and talking to my provider, what I actually realized is, I had years of terrible nutritious habits, right? And if I go all the way back to the beginning and think about, well, what if back in the 80s and 70s, late 70s, when I was on Medicaid, when I was on food stamps, when I was waiting for the government food truck to come up, when I had housing assistance, I was thinking, geez, what if some of that data that we had back then could have been electronic? That would have been stage one, of course, right? And then I think about even today, and I think, well, what if that data could have been exchanged? What if my nutrition information could have been shared with my educators? What if it could have been shared with my providers? I'm certain my primary care provider wouldn't have been happy if I was eating 10-cent mac and cheese every day. But the reality is that, you got to make do with the best that you got, right? I mean, so that's what I had, and we did the best that we could. And I'm not saying that it would have been perfect, but it certainly would have been, I think it would have made things better. And so I think about that, and that was 35 years ago. And what's interesting is we come kind of fast forward, and even though we do have electronic data today, obviously in all of these areas in health and human services, I kind of put out there, have we come far enough yet? And of course, I'm going to turn it over to the panelists in a second, but I don't think that we have, of course, and I think we can all agree on that, right? So there's a lot more that can be done, and I think that, of course, that's just one example. There are many examples like that. And I would leave you with this. Can we share data? Absolutely. And I know that we can share data because I'll give a completely different example. I went to the registry and I wanted to renew my registration, and I couldn't. And said, what happened? They said, well, you've got a ticket on here from California. Well, that's interesting. So California found a good way to share data with the Massachusetts Registry of Motor Vehicles, and they got that data over there. So come on. Now, if we can share data like that in the name of making sure that they get their money, I'm sure that there are ways that we can enhance data sharing, in something as important as health and human services. So let's we're going to go across the panel. I'm going to start with Ellen Marie from CMS, and everyone's going to give a quick introduction on who they are and just what they're tackling from a day-to-day. So we're going to start with you.
Great. Well, thank you. Is this working? And thank you for inviting us to participate in this. In my 5 minutes, I'm going to quickly touch on 3 different things that I think are key to how we at CMS are looking at this, and I think as the nation is now perhaps spending more time looking at the linkage between what's happening in the healthcare delivery system and human services. The first being that I think one of the reasons that we're talking more about this, with my payer hat on, is because of the way we pay for healthcare. Second is, I think the movement away from fee-for-service is probably here to stay. And third, and obvious to everybody in this room, is if we're really looking to measure patient outcomes, we have to be able to measure what we're trying to do. So the first part is the fact that we're now having a broader discussion about what's happening outside the healthcare delivery system and the importance that that plays on the patient outcomes. My background is a clinician, a pediatric clinician, so as I was practicing, very clear that what was happening within the healthcare delivery system was only a small part of what made my patients healthy. Unfortunately, back then, the payment system didn't support that. As we've moved now away from fee-for-service to a bundled payment, a shared savings model, and we are needing to better understand how patient outcomes are affected, clinicians, health systems are forced to better acknowledge that what their role is in keeping patients healthy sometimes has not a whole lot to do with the patient actually being healthy. 80% of our healthcare dollar nationally is spent on managing folks with chronic disease. And the majority of what helps someone with a chronic disease stay healthy doesn't occur in the 30 minutes with their doctor once a month or once a quarter. It is the way they're eating. It is all sorts of lifestyle changes. And as we started to move payment to be associated with how patients are doing, health systems are needing to better understand, wait, this is not just what we're doing inside the clinic walls. We need to better understand what's happening outside the clinic walls. The second is the fact that I think value-based purchasing, alternative payment models, is the direction that we're going. I'm not sure we know exactly how, but we think we know that fee-for-service is broken. Just paying for more services without recognizing and measuring whether or not the patient's getting healthy is the way to go. We need to move away from that fee-for-service. And we're seeing the traction. CMS has been working closely with all sorts of payers in the Healthcare Payment Learning and Action Network. If you don't know what that is and you'd like more information, I'm happy to share. And it's looking to have all sorts of stakeholders come together, including lots of private payers, states, Medicaid, to say, where are we going with alternative payment models? And just the end of last year, that organization, the Learning and Action Network, did an assessment of Medicare private payers, some Medicaid, and saw that there is a significant movement. The majority of payments now are moving in the direction of alternative payment models. That was last year, and now I've been working more closely with the MACRA, Quality Payment Program, which is now in law. It was overwhelmingly bipartisan when it passed through Congress, and I'm sure most of you know, but this is a significant change in the way Medicare providers will be paid, with a merit-based incentive payment system, which is looking at outcomes, quality improvement, perhaps bonuses for caring for vulnerable populations, so really moving away from just being paid for those services. And in addition, there is an extra 5% bonus for those alternative payment, for those clinicians that are willing to take a little bit more risk and move into what we call an advanced alternative payment model. So that's well underway with strong bipartisan support, and I think is sending us in the direction that we know that we're no longer staying with the fee-for-service system. And the last, which I think is a critical piece, and I'm looking forward to hearing the panel as well as discussions here, is of course we can't do any of this if we can't measure, not only document the interventions that are happening, but also be able to measure whether or not the outcomes have occurred. And there are lots of examples, and I think you're going to hear many more on the panel now, where we're seeing that an intervention that may happen in the healthcare delivery system may have that improved outcome that occurs outside the healthcare delivery system, or vice versa. Something outside the healthcare delivery system, Meals on Wheels, for example, we are now seeing may have an effect on cost and quality inside the healthcare delivery system. Is it preventing folks from going into long-term services? And so better understanding how these two, how we can take measurements, data occurrences that are happening outside the healthcare delivery system, merging it, not just for the sake of measurement, I think for us as clinicians to better understand what is it that we're doing and can we track this over time. It's an important issue when we're talking about total cost of care. which typically is the total cost of the healthcare delivery system when we think about it. But it's an interesting thought to say when we think of real total cost of care, that's much broader than just what happens in the healthcare delivery system. And one of the things I'm looking forward to on the panel, as well as the discussion, is I would throw back to you, is in the work that you're doing, where should we as the feds be looking? What are things that we could be doing that help facilitate this work? What's standing in the way of you doing an even better job? And I think with the panelists, we're going to hear that and look forward to the discussion, to hearing how we can kind of step up to the plate and continue to help all of you move in that direction.
Thank you, Marie. And so we're going to move along, and Meghan, please give an introduction, and we'd love to hear some more about what you're doing.
Great. Thank you for having me. My name is Meghan Vanderstelt. I'm with the Michigan Department of Health and Human Services, and I serve as the Division Director of the Policy Area, and we oversee a lot of the strategic efforts and strive for strategic alignment across a variety of our different transformation efforts, large initiatives, and the like. Some of which are span a lot of different areas across the department, and so we could try to serve as kind of a coordination point for those, including our behavioral health, physical health integration efforts, our state innovation model, as well as some efforts underway with the opioid epidemic, health equity, and continuous efforts towards our recent merger. About 2 years ago, our department, the then Department of Community Health and the then Department of Human Services, underwent, and we still continue to a certain extent, a large merger of those two areas, both from an organizational and a programmatic sense. And it's a work in progress, and I think a lot of the best practices, tools, and efforts that were underway on both sides of those areas are really getting to be further integrated and leveraged in new and exciting ways as we move towards larger care coordination, health and human service integration, and a whole host of different initiatives that Michigan's involved in.
Thanks. So, Eugene, obviously more than just your Wi-Fi that's on my badge. I know you guys do a lot more over there, so can you please talk about some of the things you're doing?
Sure. Good morning, everyone, again. Softheon is a technology company located actually within the grounds of Stony Brook University. We are about 150 people, and over 100 of them are computer scientists, data scientists, and applied mathematicians and whatnot. So dating back to after taking part of the early implementation of what we know as a Romney Care back in 2008, as the ACA became the law of the land, we looked into the similar kind of analogies, being a kind of quasi-academic institution, all the way from how does the ATMs are connected to one another, to travel industry, how does Travelocity pull all the data from all the airline hotel informations and everything else. Based on that premise, and following the famous Wayne Gretzky quote, I skate where the puck is going to be, we felt at the time the puck was going to be more towards a distributed, we call the supply chain model, as we have seen in other industries. So with that mission in mind, we build that hub and spoke, if you will, platform, which follows pretty much to the T, all the MIDAS specifications. Fast forward today, on ACA, over 63 carriers, they feed their planned product information to Softheon. Softheon as the kind of the entity below the waterline in a typical iceberg situation. Not that many consumers know about us, but we manage over 2 million lives that are enrolled on ACA today. So if you make that close analogy, we we manage, I should say, over 35% of the supply on ACA, and managing roughly about 20-25% of the demand. And yet, really nobody knows about us. We are kind of the Foxconn of iPhone, what Apple does it and what Foxconn does it all together too. So we are always below the waterlines. being our inaugural event in here, why we're here. We believe the time has arrived for healthcare and government to take on a more COTS approach. We have seen the examples of, taking on a project like ACA, where everybody thought it will be a very simple slam dunk in early days. I think when we realize the impact of the consumer regulations and whatnot. So the way we operate is a system of complete real-time interfaces, meaning that we have some carriers, and in fact, out of the 2 million, roughly about 1 million of those lives, we actually enrolled and effectuated, meaning that we received the 834s from the federal and state exchanges, whereby we do the additional enrollment underwriting. We do a lot of scrubbing of the data. Once we do that, and then we do the billing, and we do the collection, in that sense, kind of we are the eBay and PayPal. Once that winning bid, as eBay does it, that's the only one that arrives at the manufacturers for fulfill their products. We do the exact same thing. So once the member becomes effectuated, that is the time that we send that member downstream to our carrier system. So this way, they don't have to make any modifications in their assets that they have built over the last 15, 20 years. So we move upstream all that ACA complication, all that business rules, and our team does it for not just one carrier, but 60+ carriers. So that gives us the opportunity to really build our best practices. So as a COTS platform, we provide the hardware, the software, and services, meaning SaaS, software as a service, as well as business processes as a service. Case in point, testimonial recently, literally as late of October of the past year, we signed up a health plan out of Texas, and within 17 business days, we were able to enroll and effectuate members through Federal Data Hub and FFM on exchanges. So it's a totally different model, and we are now in conversations with multiple states about how we can help them, meaning how can we put our technology upstream to the state level, all the way up to the integrated eligibility component to it, enrollment, underwriting, whatever that might be. So that is our focus, and I look forward to hearing your questions and conversations.
Thanks, Eugene. Brad, so last but not least here, and other than everybody asking a question about whether the Cubs will repeat, what's going on over there in the great state?
Thank you very much. Good morning, everybody. My name is Brad Long. I am the Illinois Department of Innovation and Technology Families, Children, Elderly, and Veterans Cluster CIO, and I'll tell you that so I can tell you this. Back in July, the state of Illinois combined all their IT into one agency called the Department of Innovation and Technology. The CIO, Hardik Bhatt, or the actual secretary of that state CIO, decided that we needed to have clusters or lines of businesses. So we have one for public safety, which involves corrections and our state police and everything else. I have all of health and human services. So that's how my role here is. Part of that job is to turn around and look across the enterprise and find synergies on where we can turn around and take things that already exist, leverage them in order to turn around and provide better, faster solutions. Part of this, for me, has also come into the fact that I've been involved with analytics for a very, very long time in previous life, and I've done it with logistics as far as supply chain, crashes with Department of Transportations, and you know what? It's like we can do the same thing with health information. All right, if we can track it, figure out how we're going to bring it in, then we can turn around and get that integration of data that will actually, and as the title of this says, make that data actionable. That's the biggest thing, and not actionable at a policy level, but also to that field worker who's sitting there that needs to make a decision, so that they're making the most, the best decision possible based on the data that they're doing. Part of my job as a cluster CIO, we've invented or come up with innovation incubators. So I also got the title of Director of Health and Human Services Innovation Incubator. And part of that is a Person 360, which some of the folks learned at the roundtables this morning, what we're doing with that. It's a holistic view of an individual, so we can really turn around and focus on the two main initiatives of the state of Illinois, and that is data-driven decisions but better yet, coordinated service delivery. And so that piece there, combined with the back-end piece of our secure harmonized data pool, will allow us to provide the data that we can now do prescriptive and predictive analytics to help achieve the outcomes that we're looking for. So, thank you.
Thanks, Brad. So, obviously we've got a tremendous amount of experience up here on the panel, and so as I think about everything that you guys are talking about, why don't we focus in on, and Brad, you just mentioned the 360, and I know some folks are familiar with that, and we can either talk about that or another one, but let's start with you and talk about some of the success you've seen here. Talk about maybe a current initiative and talk about maybe a vision for where that current initiative or even a new initiative might go. And so why don't we start off with you?
Thank you. So I think with the Person 360, and as we stated at the roundtable this morning, one of the biggest things that we did was we created a thing called the Enterprise Memorandum of Understanding. 13 agencies within the state of Illinois, their directors and secretaries, as well as their legal counsel, got together and signed an agreement that we would share data amongst agencies. Now, we still have our security and privacy compliance that we adhere to, but it kind of took and changed the whole dynamics of the conversation, where it's not, hey, can I have your data? No, you can't have it. Well, why can't I have it? Well, because I said you can't have it. To, all right, tell me why I can't have it. What policy, law are we going to break if you share that data with me? And this is how I'm going to protect it then. So I think that was probably one of the fundamental things that happened in Illinois that promoted the whole 360 and bringing data together. I guess the visionary thing that we're doing now as far as analytics, and this is all based around the Person 360, we've been working with some folks right now in the medical profession that are looking at almost cognitive processing to turn around and be able to, by a picture of a child, bounce it off a database and be able to tell with certainty that injury was a playground related, or actually if it was really abuse or neglect. So one of the big things that's trying to achieve is we found out that they were taking some folks, taking kids out of their home prematurely to find out it was just something that happened on the playground. So that's one of the things that we come up that we think that's really, really, really going to be something visionary and going forward. But yeah, I think that's there.
Thanks, Brad. I mean, that's some amazing work they're doing there. I mean, I know we talked on the phone about that, and the ability to be able to use analytics to look at a picture and determine what the source or the type of abuse that might be going on it's beyond what I think people would have thought could happen. So obviously we can see the relevance in that, especially in the child well-being space. Meghan, I want to go over to you for a second because the word 360 comes up again, because I know that you all have your own kind of initiative around that. So maybe you could also talk about one of your successful programs and what you're doing right now, and also give us a little bit insight into the vision.
Sure. Michigan has a strong history of leveraging data sharing and technology in kind of new and exciting ways. And one of our efforts is our Care Connect 360 tool. It was really derived initially from a Medicaid space for larger care coordination. And the Care Connect 360 tool is a statewide care management web portal. And the intention being giving that 360-degree view of a beneficiary and providing a broader view of what programs are applicable to that person, a kind of a standpoint in time of what kind of care coordination is happening or can happen. And it really started with our Medicaid health plans and our behavioral health payers acknowledging that there is a lot of shared care coordination potential, and the Care Connect 360 tool kind of provides that platform from which to do that. And then as that has really grown and expanded for those particular purposes, some new opportunities arose to kind of leverage that in a greater capacity, and particularly on the human service side most recently. So, for example, we recently have expanded access beyond just those payers that I mentioned, in addition to some providers like FQHCs, among others, and other program areas. But most notably is our human services area and our child welfare area. And the Care Connect 360 tool provides a window opportunity into a child's healthcare needs and what kind of programs are applicable to them in a more timely fashion that was previously available. And I think that it really kind of broadens that definition of care coordination beyond just the healthcare space, although we are talking kind of predominantly about healthcare information, but really bridging it with kind of our human services elements. And I think that served us really well and actually has provided a nice springboard into further integration efforts. And I mentioned earlier our recent merger as the Department of Health and Human Services. And this is really a new opportunity to kind of envision in the way in which we do service delivery in the broadest sense of that. And there was kind of 3 critical objectives that kind of emerged from the merger. And that included these objectives of considering service delivery in ways that recognize and support the unique needs of an individual, really kind of that person-centered approach. We also really were looking to work with partners, both community-based groups and others to support and assist the folks that we serve in Michigan in achieving self-sufficiency and greater independence. And lastly, also to further our goals towards education and encouraging an individual and the community to really seek and support healthy behaviors. And this really kind of encompasses what we call our integrated service delivery model that we are looking to implement here soon. One of the key tool enablers in helping us realize that is a portal design that allows folks to, in one centralized place, assess the needs and connect our folks with the different supports, including community-based groups that would assist with those efforts. And this is coming both, again, from a healthcare and a human services perspective. And ultimately, we're looking to meet the goals and create goals and improve and create greater stability for the clientele we serve. The portal really centers around relationships with a holistic process in mind, and it really provides an opportunity for those common processes to be accessed more easily by our different groups, and is redesigned within a user-centered interface that has the option for self-service potential. It's really no different than I think how anyone would really want to access a variety of different customer service opportunities. In fact, there's also the ability to, for example, upload validation documents via a mobile device or your cell phone. And I think that's really important in meeting the customer needs in a person-centered approach and really coming to them and utilizing our technology in new and creative ways. Other efforts that are also part of this integrated service delivery approach include a universal caseload management, and it's really promoting the sharing of casework across different teams, which we really feel will improve not only the caseworker experience, but ultimately also our customer experience, because it's really about that at the end, of course. In addition, we're looking towards a more centralized phone system as well, too, so that most of the questions or concerns that our folks might be calling in for can be addressed in a more centralized place versus kind of on a program-by-program basis. And it really, again, speaks to that person-centered, more holistic approach that we as a department are seeking to achieve. So those are a couple of things, some of which that we've had prior merger, but certainly are kind of have been great lessons learned and further springboard into that broader integrated approach.
Well, thanks. I mean, I think, again, you know, we're excited to have the states up here, and I know a number of other states are doing some amazing work as well, but a great example, again, I mean, this work with the 360 is fantastic. And Eugene, I want to go to you for a second here, because you're sitting here listening to some of these fantastic innovation efforts that are going on at the state level across health and human services, and you spoke, of course, about what you all are doing, and I'm very fascinated by the approach you guys have, because you mentioned kind of looking outside the healthcare sector and bringing some of the lessons learned from there into healthcare, which I think we all want to see more of, because it happens quite a bit outside of healthcare. Do you want to give some example of some of the success that you've seen in the vendor community and some of the work that you've done, maybe an example or two, and where you see this going with vendor participation?
Sure. As I mentioned earlier, kind of following the paradigm that we see in the other industries altogether too. So our mission has always been around turning data into action. And I'll give you 3 examples of that in the context of ACA. Granted that ACA has been our linchpin implementation, and building on that success, now we're in focusing on different areas altogether too. One of the biggest challenges for carrier was the validity of the data they were getting from CMS or even state exchanges in general. So what we have done is basically we have built a complete another set of underwriting all the way from identity verification to rate verification and everything else. So if any one of the data elements did not really match the carrier's specification, for instance, there were some carriers will accept a life partner as a dependence where otherwise did not include. So all these little outliers, the anomalies that, I'll call the 20% of your work takes 80% of your time, we focus on those areas to bring efficiencies. So that was one of the examples that we were able to identify and pinpoint those items, and we will personally reach out to those individuals. We do want to provide access to healthcare. We want to give coverage altogether, but we also need to worry about a sustainable business as an entity, which has been a big problem, as you know, all the way from Unitas and Aetnas of the world. That's why they're pulling it out, and that is not a good thing in this space. Another actionable process we put together was, after the enrollment is done, the phenomena called third-party payments. This happens especially around the special enrollment. Here's a use case for you. Someone doesn't have a healthcare coverage, they get sick, they go to a doctor or some facility, and then the providers, whoever that is, advises that consumer to say, go get a health insurance. Again, these people, unfortunately, there is a small percentage of the population still do not take care of their well-being. And at that point, that individual is then being redirected to some third parties. And all of a sudden now you are seeing an enrollment within 24 hours of the effectuation, and this person is going to California, whereby it might be in a state exchange up in, let's say, up in somewhere in the Middle Atlantic, and then all of a sudden that you're seeing these $15,000, $20,000 utilization. Now, we're not against that concept altogether. However, we need to also, once again, create a sustainable program. Healthcare is one of those very unique industries that I'll call it an industry or market, is that you have a fiduciary responsibility providing access to healthcare altogether, but you also have to do it and within the reasonable range. And that equilibrium that exists in any other market, you look into travel industry, how the seat of a airplane just goes up and down based on the time. So that level of engineering, real-time decision-making, this is something that we provide altogether. And the third one, we did it on a more of a pop health basis. We are able to create almost like similar to FICO score, I will call it a health score, because our goal is there to also identify people with overutilization or underutilization. Based on their trending activities, we are able to today we take the claims data from all our carriers. We already have the enrollment data. We already have their financial data. As I always say, I've never met a wealthy individual as in a poor health. Maybe there is a few anomalies altogether, but your financial well-being is a strong indication of your physical well-being. So we basically have a health score of every one of our 2+ million lives that we have it, and we use that data for a proactive reach-out programs to really make sure those individuals are being informed, educated. So as part of the effort, we provide a lot of those, I would call the services as part of our best practices.
Well, thanks. I think we'll be interested to see how things progress, of course, with some of those. I mean, that score is definitely fascinating, and I think it could obviously be enhanced even more as we bring more social determinants and other data that might be available. And Elmarie, we'll go over to you. Again, you've listened to some of the amazing work that's been going on here from a federal perspective, and a lot of the great initiatives that you guys have, obviously from the innovation side to helping with waivers, and everywhere in between. There's so many things that are going on. Do you want to talk about some of the work that CMS is doing as well?
Sure. Thank you. And I can't wait to have further conversations with all of you. It's really exciting, the work that you're doing. And I think I'll talk a little bit about what we're doing now, but also would love to learn from your experience to see what is it that we could be doing more of. What's in our toolbox at the federal level that might be not facilitating the work you're doing? What's standing in the way of you actually being able to do a better job? And are there things that we may not have even thought about that are getting in the way? It's one of the things that at the Innovation Center, we often pose to our clinicians or awardees to better understand what is it that they wanted to do that they couldn't because perhaps there are certain things that CMS has put in place that was standing in the way of success. So we'd love to explore that more. I think the things that we're doing now, of course, is mostly in terms of payment. So we're paying differently for healthcare. Certainly at the Innovation Center, we have the state innovation model, the SIM awards. They've been given lots of infrastructure dollars to help states think about how they can transform care delivery, looking for multi-payer alignment when that makes sense for states. It certainly makes sense for clinicians, makes life a lot easier when you've got all of your payers moving in the same direction and asking you to measure the same things. So we're looking to support that through the funding, but also technical assistance for some of these activities. We have an Innovation Accelerator program, which is offering technical assistance to states to help them look at their own initiatives, but also provide opportunities for states to learn from each other. One of the things that is particularly challenging, of course, for states is they are developing their own payment models in instances. They're trying to implement it with very small infrastructure, and not a whole lot of capacity in many instances. Whereas we look to see what we're doing in the Medicare world, and we oftentimes create the payment model and then just allow folks to apply for it. And on the state side, we're actually asking them to create these new care delivery models, new payment models. So wherever we can help with technical assistance there, we're looking for opportunities to do that. So through the Innovation Center, not just at the Innovation Center, not just through our SIM awards, but we're also looking to have the other models that are moving forward to better understand how they can be offered and integrated into a Medicaid world. So our Comprehensive Primary Care Initiative, we now have 8 state Medicaid agencies that are strong partners. And when we've talked to them, it's been great to hear them celebrating the fact that they are not only invited to the table, multi-payer alignments didn't oftentimes include Medicaid, but when they got to that table, they were able to demonstrate some of the successes that they were doing and have some of the private sector actually learn from them and use some of those models. So I think like some of the stuff that you're doing here, we know that the innovation is often happening at the state level, so trying to find opportunities where the state can take what they're doing and try to move the needle on healthcare broader than just the Medicaid. And I think last would be the work that we're doing just through our general course of business, so SPAs and waivers, DISRUPS, which is a waiver that looks at transforming practice and innovation practice. And we think that there might be more of that in the future. State innovation is something that we've always tried to celebrate and look for opportunities to have states address the needs of their specific communities. That said, we also want to make sure that there's not only 1,000 flowers blooming, that there's some way to learn from each other. And I think one of the major things that we're doing, and Jess Kahn, who is here, who is the director of our data systems group and the empress of our Medicaid data, has been working tirelessly in our transformed Medicaid information statistical system, TMSIS, to look to see how we can have states reporting data in a similar fashion, expanding the number of elements that they are reporting on, and that not only benefits the states so that they can better evaluate how they're doing in any of these models. It is a requirement of sorts for some of our, when a state wants to apply to the Innovation Center. We have to be able to evaluate that. Every model at the Innovation Center, when it gets started, the statute says it has to be rigorously evaluated. And the only way to do that is if we have the data to be able to do that. So the TMSIS is often a requirement that a state has that up and running. Our Innovation Accelerator program is looking at helping states do data analytics. One of the places that we're starting, because we have it in-house, is how to better merge Medicaid and Medicare data, but also looking for opportunities to then look at data analysis. When you have that have the data, have the numbers, how do you turn it into information? And that's not so easy, as folks here know, when you've got lots of numbers and you need the capacity. So how do we help states evaluate the data they have in front of them to do a better job? So I think bottom line is looking for new ways of paying for care, looking for new ways to help states deliver the care. So I think we like to think about creating payment models that can support these innovative ways of doing care. It shouldn't be the other way around. We should have payment models that help support the good care delivery models that are out there. But then also just looking at that data, making it easier to report, making it more comprehensive and comparable across different states, and then ultimately making it available to whoever wants to take that the data, turn it into information. I'm a former health services researcher and know that we can't fully understand where we have our successes unless we have those data available to folks to dig in, take a better look at, and help us see what direction we should be going.
Well, thanks. I mean, and I think, again, we're looking forward to hopefully a strong next couple of years. Obviously, everyone's aware there's always a lot of question marks going on right now, but I think we saw, some commitment recently, the letter that went out to Medicaid directors, which seemed to affirm the commitment towards innovation and expediting the waiver process. Certainly looks very encouraging, and I think everybody likes to hear that. And so let's go over to you, Meghan, for a second. And what I wanted to have you talk about is that this is not an easy process. Health and Human Services, trying to share data. Brad touched on it, and we're going to touch on it more, and everybody out there is probably wondering. There's a tremendous amount of barriers to get to the end game here. Can you touch on just some of the major challenges that you've gone through, either from policy or funding or data sharing? I mean, what's been your experience so far?
I think it's safe to say integration is challenging. Integration's hard, but I think there's a lot of opportunities that arise with that. There's a couple that come to mind. So one is kind of one that we're kind of in the works of right now, and I think there's great success, and I think our state innovation model opportunity has been a great vehicle for further growth in this area, and that's quality metric alignment. And it really speaks though to kind of a shared understanding and a definition of what we might be talking about, and that spans health and human services too, of course, and it just makes data sharing all that more easier once you kind of establish some of those rules of the road, from then which the data can then follow and is that much more interoperable or digestible to other folks. And in the case of quality metric alignment, we're doing quite a bit of different work with both our providers and payer communities in understanding the varied ways in which they're doing quality metrics and how they're exchanging that information. And what we found is there is kind of a middle ground, so to speak, or some consensus around how we should be achieving this. And again, SIM's been an awesome opportunity to kind of further that along, pilot some ideas, and kind of look towards use cases that enable that further. So that's definitely an area that's in the works. Another challenge, but I think opportunity in the same right, is this idea of coordinating the coordinators, so to speak. And I mean that again in a broad sense, both the health and human side, because I think a lot of folks are dedicated to really serving the individual and providing a key piece of coordination in their kind of piece of the world, right? But then it's a different challenge, especially from a data sharing perspective, of how do you connect the dots across those folks to essentially get the right information to the right person at the right time, and also the considerations related to consent management along with that too. So it's kind of a layered thing. I think once you start moving information around, then it becomes some of those new interesting policy questions emerge that we're kind of at the cusp of exploring. Again, the state innovation model is an opportunity to do that, since our efforts in that space, among other initiatives, are really that bridge both from the health side and human. And particularly when you start talking about the more community-based groups, how do they fit into that equation? Especially as the health side might have had a little bit more experience in some of that coordination elements and the data movement around that. But then how do we incorporate some of the community-based groups or those folks dedicated on the human side within that? So it's something that it's a challenge, but I think it's an excellent opportunity and something that we're looking to explore and kind of leveraging those building blocks we've already established. But I think it's going to be an evolution, and a lot of, we're just going to have to remain agile as we kind of forge ahead with that.
That's great. I mean, I think we all are excited about the work you're doing, and hopefully it continues to move forward like that. And we'd like to hear more about those challenges as they come out, and hopefully be able to conquer them, of course. Eugene, slightly different perspective, of course, from the vendor side, but talk about some of the challenges that you've seen coming into this market, and perhaps even also talk about what could maybe states and feds do to better encourage vendor participation. I know a lot of times the vendor community out here is sometimes you feel like it's opaque, and sometimes it's not. So again, let's hear about your perspective.
Absolutely. I think just following two problems that we see. One is the data, in which we are absolutely big fan of the data.gov initiative, for instance, what's happening at the federal level, able to access to data, because unfortunately the data has these especially the healthcare data has these three key attributes. One is volume. The volume is immense. Variety is so many different forms of the data. Access to provider data, even today, is such a difficult task because most of our consumers, members, they want to choose their plan coverage, not based on sometimes, some do based on price, but others want to choose their plan based on provider and their drug. Is my doctor accepting this? Which plans are being accepted by my doctor? Or which formulary, which drugs are accepted by this plan? It's been a very difficult part, and to be frank with you, that's one of the biggest area of an interest to us. If we're able to put together a data set that gives us that capability, that we can help really make that guided experience in terms of finding the right product, right coverage for those individuals altogether too. And then the third aspect, of course, the speed of it, that we need to be able to provide the data. The data is good as long as it's fresh. And you can torture the data, it'll confess anything, but sometimes that will they'll force you down to the wrong path altogether.
Thanks, Eugene. And I think as we move along, Brad, certainly you've had your fair share of challenges you've gone through, and you hear about some of the things you've done. And as you touch on some of the challenges, also I heard Eugene just mentioned something that we all think about, and we should put at the top of this list, I think, many more times, is consumer engagement. So you could touch on some of the challenges, and if you have any thoughts on better ways to get consumer engagement, I'd like to hear about that as well.
Thank you. One of the things with the creation of the Department of Innovation and Technology is our CTO has a very strong mobile initiative called Illinois First. So everything that we do from here on out really has to be thought of as a mobile application. And the intent is that everything that we do is connected to the citizens. The individuals, they have access to any of the services. One of the things that they came up with was a mobile app called, play on words, capital I, capital L, Ocator.com. And it's a place where you can go mobile and turn around and search for any service that the state offers. And it'll give you a GIS, here's the map, here's where the location is, you can go to seek that service. And we're adding those as we continue to go in. So that's one of the big pushes with that. Everything that we do now is really all about the citizens and how we interact with them. I heard Meghan talk about being able to upload paychecks or, for certain eligibility things. We have similar initiatives that we're doing with our Medicaid, SNAP, and TANF initiative. Everything that we do, our child support systems, everything else is really driven by that ability to have the individual almost self-serve themselves. So that's really where we're at on that. And then, we circle back around. I don't know if we'll get to the point, and I like the way Meghan spoke about it, but even with the Person 360, and then, I'm going to circle back to yesterday's discussion with blockchain, if an individual can really see what we're doing for them and how we're doing it for them, and they have that, oh, yes, I've got this, and here's a text that says you have a doctor's appointment tomorrow, or you need to go see this person. I mean, that's really where, I think we really need to be, so that it's, a constant, interaction with the individual, and not them waiting around for somebody to pick up the phone and call them. So.
Thanks again, and again, some fantastic work there. Love the idea around the mobile engagement and keeping the consumer at the center here. And we're going to kind of finish things before we have a chance to maybe ask a few questions from the crowd. But Marie, see, you've heard a lot from the federal side about some of the challenges that the states are going through, and some of the work that the vendor community would like to see. Oh. Oh. We have a real fire alarm. So there's one challenge, huh?
Was I saved by the bell?
You were saved by the bell. Well, thank you.